colaboração com a Faculdade de Medicina da Universidade Federal do Rio Grande do Sul. Hoje nós estaremos abordando o tema uso das ferramentas digitais na saúde mental. Esse encontro será conduzido totalmente em inglês e logo em sequência nós estaremos fazendo a conversão da língua. Welcome to the grand round of HCPA. Today, the main subject of our meeting will be digital mental health. The main focus will be in attention deficit hyperactivity disorder. Attention deficit hyperactive disorder is a diagnosis recognized by the American Psychiatry Association and characterized by hyperactive and impulsive behavior, which might be manifest both in children and adults. Today, we are going to analyze the use of new multimedia interactive resources to evaluate and treat attention deficit hyperactive disorder. Will participate on this meeting Dr. Luis Augusto Rodi and Dr. Giovanni Salum, both professors at psychiatry at the Federal University of Rio Grande do Sul, and our guest, Dr. Scott Collins. He is a professor in the Department of Psychiatry and Behavior Science at Duke University School of Medicine. Now I will ask Dr. Rode to better introduce our guests and make some comments about the highlights of our meeting. Please, Dr. Rode, go ahead.
Good morning. First of all, thanks Professor Jaime Fleck and Professor José Geraldo Ramos for inviting us for this grand round. And thanks to Professor Giovanni for sharing his data on our high-risk cohort and some digital mental interventions that we are implementing there. And a special thank for our guest, Professor Scott Collins, who will present on the first ever video game approved by the FDA for treating a mental disorder. And what is interesting about it, that is a video game that need to be prescribed by a medical doctor to be used. I will introduce the subject. Let me share with you my screen. Just a second, let's see. Okay. Okay. Well, I will talk about the focus ADHD, the trajectory and missteps in the development of an app for ADHD. These are the disclosure of my potential conflicts of interest. And in what context we'll be discussing digital mental health? We are discussing in a world 2020 where more people have a smartphone than clean water, indoor plumbing, or stable electricity in their houses. There are, in 2018, 1.7 billion people downloaded mobile health apps. We have more than 325,000 apps in different health domains for choosing, making very difficult to be updated on everything in this area. But what is important here is that the majority of apps that we have for mental health and for health, they are, when you assess the quality of the app, they are just in level 1. They have no data on privacy and security and no evidence-based data on the effectiveness of the intervention. Some of them just jump from the level 1 to the level 4 without checking the effectiveness and the privacy and severity. Why to talk in a grand round about ADHD? We published several years ago a paper that is now the 6th most cited paper in all the 6,000 papers on ADHD in the Web of Science, clearly documented the high prevalence worldwide of ADHD in children and adolescents. And more recently, different groups published using the Scandinavian medical registers and also the Taiwan medical registers a higher mortality rate in children, adolescents, and adults with ADHD than the mortality rate in the general population. and mortality associated with non-natural causes like accidents. So ADHD is a very important and relevant mental health disorder. What are the problems in the ADHD field that are similar to the problems in other mental health areas? First is the way we assess treatment targets. The traditional approach in our settings is to ask open questions to the patients or the families, like how symptoms progress with treatment since our last appointment, or the use of scales to assess pre and post-treatment. What are the problems with this kind of approach? First, we have a huge symptomatic heterogeneity across and among the days, as you can see in this figure. And also, patients and families do not remember the progress of symptoms among spaced in time appointments. So we need other techniques and approaches to assess symptoms. In addition, as you can see here, there is more than 25% of the treated patients never fill the first prescriptions. And the reasons for this non-compliance are adverse events and suboptimal response, the main two reasons. So ADHD is a chronic disorder, and as hypertension, diabetes, or epilepsy, we have problems with compliance. And in ADHD, even more, because the core symptoms of the disorder, inattention, impulsivity, executive dysfunction, intolerance to routines, the core symptoms clearly impair the ability to adhere or to have compliance with the treatment. The same in Brazil, it's not difficult. This is a study published by the group of Professor Eugênio Grevet from our ADHD outpatient group. They clearly documented that in adult patients with ADHD, 65% of them discontinued treatment in a 7 years period, even having a positive ADHD diagnosis or when they have subthreshold symptoms with clear impairment. So compliance is a problem, as in all chronic disorders. And then in the last 2 years, 2 to 3 years, we have been seeing in the literature some developments like the one in the left side. This is an app from Israel, and here is an intervention from the Harvard group that combine the same elements, 3 main elements. The first one is psychoeducation. The second one is digital assessment of symptoms, assessing symptoms randomly in different times of the week, and also monitoring and stimulating medication with reminders when the patient have to take the medicine. And look here that we have an increase. This is treatment as usual. This is the use of the app. 30% increase in adherence of treatment, and in the Harvard group with adults, 34% increasement in adherence to treatment. So we have a difference that's not only statistically significant, but is clinically significant in terms of compliance using these digital medical health interventions. We have been developing for the last 3 years the Focus ADHD. We transfer the intellectual property of this app for our university and for Hospital de Clínicas. You can find this app in the address below. And what the Focus does, it does exactly the same these other apps. We try to have an objective monitoring of symptoms, trying to continuously engage the patient in the treatment, psychoeducational, and using intelligence to make the collaboration of the patient with a network of collaborators, including the medical doctor. What is the workflow in this app? The patient, he or she, the patient or the parents of a patient, they register in the app, and they can they can select collaborators at up to 3 collaborators. For instance, an adult patient, a significant other, to monitor the symptoms and to receive reminders to help the patient with taking the medication, or if the parents can invite another parent or the teacher or someone else that is related to the child for monitoring the symptoms. And we have 3 main activities in this app. We have a weekly symptom assessment in random periods of different days, and assess of adverse events, and also Giovanni will talk a little bit more about it, about ecological momentary assessment of feelings of the patients during the week. We have also a task manager where the patient receives medication reminders, and also he or she can select 3 activities that he or she select as priorities, and they can select rewards doing what we call a behavior intervention or a token economy intervention to reinforce the behaviors that need to be reinforced. And also we have psychoeducational. 2 times per week we put ADHD material. And also the patient can connect with the health professional, and during the appointment the health professional have all the symptoms in a weekly basis, and also if the patient took or not the medication and the adverse events. So he can have much more on-time information to plan the treatment. Now we have 1,200 people engaged in our app. We have more than 500 new users per month. Most of them are adults, patients, or parents of patients. See here that we have only 8% of mental health professionals engaged, and I will address this later. 43% are psychiatrists of these medical health professionals, and from our users, most of them are women, are females. And here, as any app, you can see here the retention rate, 5 weeks, and you can see that the great challenge with the apps, as with the interventions, is the adherence with the app. Here, if you enter in the app just once per week, you consider that you have an adherence, and see that after 5 weeks, it's always a challenge to have the people engaged with the app. What we have been doing in the last year to develop even more the app, we did the first hackathon in our university hospital. It was 8 multidisciplinary teams, patients, families, physicians, web designers, IT specialists, and we made a competition between these 8 teams to improve our app and develop functions to improve the app and improve this digital solution. They suggested a lot of things. I selected some of them that we are trying to implement in the app for the next version. For instance, to have a Pomodoro-like approach. For those that are not familiar, Pomodoro is a way of dividing a task in sub-units of 25 minutes and then blocking the other functions of the app when you are dedicating attention for a specific action. We are trying to implement the suggested block, allowing a more interaction among the users. They suggested more efficient reminders for medications. I don't know if the people are aware of a way, for instance, that the apps the people who have difficulties in waking up use as an alarm, that you have to take a photo of something outside your bedroom to turn off the alarm. So we are studying, they suggested more efficient way of reminding people and be sure that the people are taking medication, and geolocalization, allowing estimation of time to arrive in the next appointment and to find the best discount drug stores with ADHD medication. And we are including the results from this hackathon in our app. What are the missteps of the process? We can discuss this more in the debate, but I would like to introduce. It was a surprise for me in the beginning, 3 years ago of this process, to understand that anything that I produce related to what I do inside the university is intellectual property of the university. I can make an agreement to receive part of the revenues from this app, if there is anyone, which we made it available for free. But this is a thing that it was a surprise. The most important thing, I'd like to see the experience of Professor Scott Collin, but is choosing the right IT people. This is a marriage that never ends. Whenever you select the people from IT to develop the technology of an app, you have to continue with them. It's very difficult to end this, and so you need to take a lot of time selecting. The journey correcting the fantasy. When we developed this app, we thought that this would be an app that the target would be the medical doctors. And we faced a lot of problems to sell the idea to the medical doctors that are very conservative about the way they do and see the patients, about having digital solutions in their environment. And we need to change the journey to addressing the patient, and the patient taking the app to the medical doctor instead of addressing the medical doctors to distribute the app or to make the patients knowing about the app. We can discuss later, but there is a huge tension between innovation and all the bureaucracy inside the public universities. I'm not talking about our center of innovation that is very agile and was very helpful for us, but the instances inside the public university is very difficult for the process of innovation. And something that I would like to discuss later, I have a suspect that the DNA for a researcher is not the same DNA for the people, for entrepreneur, or for the people in the innovation business. What is the next step? We just finished a deal with the hugest the first medication distributor in our state, Grupo DMED and Panvel, and we are preparing a randomized clinical trial where we have 300 patients. 100 will receive the focus with the reminders that we are implemented. 100 will receive the focus plus a 50% discount in medication, an agreement with the Panvel pharmacy, and a group will receive a 100% discount. And we want to see how much you can improve adherence besides the 30% that just a reminder improve. If giving reinforcements in terms of discount, what is the level of improvement in adherence that you can get? I'd like to thank everybody for the opportunity to be presenting, and a special thanks for the people in our team, the Focus, Luis Roberto, who was with me since the beginning, Natalia, who is a student from our medical school, who receives a scholarship, technical scholarship, who is responsible for putting the psychoeducation, Professor Hugo Oliveira and Fernanda from our Center of Innovation and Transference of Innovation, and the Medical Foundation, Professor Marcelo Goldani. All of them have been very nice partners. And finally, I want to share with you something that we just launched 15 days ago for those that have problems selecting schools, elementary schools for their children. We just launched, based on a new startup, a platform that you can find here that have an intelligent and innovative solution to select schools. Thank you very much for your attention. Let me...
Okay, we can move on with the Giovanni presentation now, please. Giovanni, are you ready?
Yes. Can you see my screen?
Yeah, it's okay now, Giovanni. Please go ahead.
Okay. So I would also like to start thanking Professor Rodi, Professor James, and Professor José Geraldo for inviting me to be here. It's my pleasure to be also in the presence of Professor Scott Collins and to discuss the more scientific part of this digital mental health. I will discuss in my presentation this digital phenotyping, also ways that technology can be used to measure phenotypes of interest to research more generally. As Professor Rodi said, there's a lot of hype in this field, and there's also a need to integrate these kinds of new data with more classical ways of measuring mental phenomena. So I'll discuss, my title of the presentation is Experience Momentary Assessment. This is a way of tracking mental health in a pandemic, and I will present some preliminary results that we have for using those apps for measuring mental health during the pandemic. So I think a lot of us already saw this picture. We have expected for this time to have the first wave of immediate mortality and morbidity of COVID-19, which is the first wave of the pandemic. A second predicted wave of impact on research restrictions on urgent non-COVID conditions. A third wave of impact of interrupted care on chronic conditions, and also a predicted wave of psychic trauma and mental illness problems that might emerge because of the increased amount of stress we have during this time. So although this is a predictive model based on the experience we have that stress might increase mental health problems, there's still very few data that really is tracking what's going on during this time. And it's very difficult to really understand what's going on because there is a very short period of time, and there's most of the evidence is in self-selecting samples and not really from samples randomly selected from the population, which might increase collider bias in the whole analysis. So I would like to present to you the Brazilian high-risk study for mental conditions. This is a study we started 10 years ago. So we started in 2010. We screened 9,937 subjects in the schools in the population. We oversampled a bit, having a random sample from the population. We also oversampled by children with high risk for mental disorders. And we have from this 2,500 selected from the screening phase, we have a very extensive protocol which involves more than 10 hours of psychological assessments with 2 psychologist visits, 2 speech pathologist visits, a visit with the parent. There is saliva collection from mother, father, and child for genetic studies. Children, and also for a subsample of 800 kids, we have an MRI visit for resting state volumes and white matter assessment, blood collection. So there's also a lot of biological data collected from these children. At the first wave, they were 6 to 14. In second wave, we retained 80% of the sample. Again, we repeated the visits, the psychological assessments. Children were at that time, children and adolescents 9 to 18 years of age. And again, we repeated MRI visits. We repeated the blood collection for assessment of biomarkers, and again, a series of questionnaires. We just completed in the end of last year the third wave, with retaining 75% of the sample. Again, we repeated all the measures from longitudinal comparisons. We collected expanded blood collection for all the sample. We also collected hair to investigate drug use and exposure to cortisol. We also extended this digital phenotyping for voice recordings of the interviews to also investigate if there is information about mental health during the voice assessments. And we also included the experience momentary assessment here in wave 3. And again, all the neuroimaging and blood collection were repeated. At the last wave, they were 12 to 21. And the most recent wave is a COVID wave. We just are still collecting data from this cohort. Again, we have a questionnaire that I'm going to go over in more detail. Children and adolescents are 14 to 23, and we collected information both from parents and adolescents during this time. And this is the way that I'm going to present some data today. So this is also part, we harmonize our data collection with other cohorts and longitudinal studies around the world using this crisis assessment. And also, is a questionnaire measuring out both the impact of economical restrictions, stress, and also infections and symptoms from COVID-19 in this population, both from the more social, but also for the more biological characterizations. And we also include this app. It's a different app as the one Luis is just describing. It's an app we constructed for the cohort participants. So besides having a classical phenotype from psychiatric assessments, having all the risk factors on the genome, the environment, gene-environment interactions, and social influences, we also expand into this new way of trying to understand and characterize mental phenomena using the digital phenotyping, using smartphone and sensors and passive data from the kids in the study. So here's this study is a collaboration across 3 universities. This is mostly carried by Pedro Pan from Unifesp, and here's how the app is used for data collection. We collected several information, so 4 times a day for 4 weeks. We collected data, really quick data on how the people was feeling. This is just a thumbs up and thumbs down. Happy versus sad, anxious versus relaxed. So it's a way of characterizing several times a day to understand what's going on during a day in during these 4 weeks of the installing the app. We collected data on sleep and sleep quality, about nature, the contact with nature and being alone during the pandemic. And we also collected passive data, so steps per day and GPS location to also understand and link those kinds of data with the geolocated information we have about the neighborhoods. So, and here are some new data. So I would like to a word of caution, because this is just really last night analysis. So it's a work in progress. There might be some errors, but we so far analyze data from, so given we are collecting data on the cohort since the April, we were able to construct a TAM series using generalized additive mixed models in which we account for the correlated nature of the data from April to September. So we can try to understand what's going on in the mental health of those children during the whole period in which the pandemic is unfolding. So here's just the results of thumbs up and thumbs down. And the bad news is that our mean is that 1 thumb down over the whole pandemic. But the good news is it seems to have a trend over time for both in Porto Alegre and São Paulo. For the state of mind being more towards the 1 thumb up and 1 thumb down over time. This is also an interesting thing. This is data from worries over those periods, and it seems that in Porto Alegre we have an increase in worries, which is significant also from July-August time. That's now again going down in September. And this is also saw in the feelings of being unhappy over time. That's also a peak. We have a peak in July-August that's also coming down now at the later years. And we have now also planning to correlate all those information about the mental health information we have from the cohort participants, but also what's going on in the cities and trying to understand what's going on. also the this is just a sneak peek of what we're planning. We are now analyzing temporal networks, so we can, given we have several information from the same subject, we can understand what's going on in their network of symptoms and how those symptoms interact with each other in a more causal way. Given we have intensive longitudinal data, we are also investigating what there are projects investigating the risk factors for mental health problems during this period of stress. Given we have a natural experiment happening in those cohort participants in the whole globe. And also, we are repeating the next wave of the cohort, all the brain imaging, both in terms of volumes, structural connections, and resting state activity, to really understand also what's the impact of COVID-19, if there's any, on brain development. Given there's virtually no data in this area on brain development over time. Besides all the app in the experience momentary assessment, I would also like to depict some work from Felipe. Felipe is a PhD student working in the group that's developing an R package to extract features from the voice of the participants that we recorded in the cohort, and we already have a free software called Voice that he's constructing, and it's already allowing capturing from a very specific part of the voice file in a natural processing language, extract 1,092 features from the voice of the participants, and we are now in the process of investigating the predictive ability of those features. So that's what I had. I would like to thank all the institute and all the people specifically involved in the EMA developing this work in the high-risk cohort. Thank you very much.
Thank you, Giovanni. Please, Dr. Collins, go ahead.
Great. Thank you. Thank you so much. I'm captivated already by the two presentations, and I'm really grateful to have the chance to present to you all. Professor Herode, hopefully we can follow up and have some conversations about your app and also the EMA. Fascinating stuff. So I am excited to present to you about the development of this video game digital therapeutic. And to start, just by way of disclosures, I've been busy. We work in my group at the Duke ADHD program in the Department of Psychiatry with a lot of different sponsors, both industry sponsors as well as federal and foundation sponsors here in the US. So I want to talk to you briefly, and I will move fairly quickly through the first parts of this so I can focus more on the design of the trial. Or the design and the results of the trial, but I'll talk a little bit about the landscape of digital therapeutics for ADHD, as well as the development of AKL-T01, which is the name for this digital therapeutic for which we conducted the pivotal study. So in the US, and this is true, and I think Luis mentioned this sort of early on, both for ADHD, but also for mental health broadly, it is a very crowded marketplace. There are tens of thousands of apps that are available, and whether it's specific apps on Android or iOS devices or things that might be provided on the internet, it's very challenging for consumers and for providers to figure out which one of these might provide the best results for their patients. This is even true within ADHD. This is just an example of 4 different products that are available. Interestingly, the CogMed training as well as Attentive have actually conducted some research and have some data. These other 2, as far as I know, have not. But again, just to highlight that there's this creates a lot of confusion. There's variability in terms of the kinds of data that are collected. Many of these companies that develop digital products or digital therapeutics for ADHD go straight to consumers and are charging fees for their products. oftentimes making claims that might not be warranted with lack of data. And as of at least a few months ago, there were no FDA cleared digital treatments for ADHD. In fact, there are, in the US for the FDA, which is our regulatory body, there were no treatments that were not pharmacologically based that had been approved or cleared for the treatment of ADHD. So I want to talk about the sort of development of this particular treatment along the pathway that we think about for traditional treatment development and really traditional pharmacological treatment development. Usually what happens when there's a new entity, and there's, as you all know, there are many approved products, medication products for the treatment of ADHD. These usually start with an idea or some preclinical work that then leads to early phase human studies that, if successful, lead to what we call pivotal studies, which are sort of the definitive trials to demonstrate efficacy and safety, and that is then used for the basis for regulatory clearance, for FDA clearance. So I want to talk about the development of this treatment along the same line. So let me tell you first, just in general, about what the treatment involves, and also to highlight that, you know, I was not involved in the development of the treatment itself. I was engaged, as I'll describe here, along the process as a person who's a clinical trialist to figure out the best way to actually conduct a randomized trial with a digital therapeutic. But the intervention is based on a multitasking video game where patients have a tablet and they're driving a character through various worlds. So there's a motor task where they have to continuously update and monitor their motor activity. And then at the same time, there's a perceptual reaction task where they have to respond to stimuli that are appearing on the screen, but withhold responding from other stimuli. The intellectual property, the thing that really makes this sort of proprietary for Achille, which is the company that developed this, are the algorithms that underlie that the video game, how it progresses, how the rewards are looped in, and so forth. I should also say that this is delivered in a very sort of high quality consumer grade sort of video game interface. So it looks and feels like a game that you would buy for your game console. So the work of this, and like I said, I want to move relatively quickly, so forgive me, but this was originally developed in the laboratory of Adam Ghazali at the University of California, San Francisco, and he wanted to test whether this prototype that he had developed, which is a similar multitasking game, could be effective for improving cognitive performance in older adults. We all know that as we age, there are decrements in cognitive functioning, and he wanted to see if this particular prototype for a specific kind of cognitive performance could be rescued by using the prototype. So he got older adults, he administered them cognitive battery, and gave them the task for 4 weeks, where they were doing it daily, and then reassessed after 4 weeks, as well as 6 months later. And these were the results. They were published in Nature. This was now 7 years ago, which speaks to the sort of the timeline for developing this as a treatment. This is the cognitive performance of different groups of individuals over time. So as you can see in there, as people get older, we see this age-related decline. This was the group in their 60s and 70s that he targeted with the intervention. And as you can see, the people that got the full prototype for 4 weeks performed at a level that was better than people 40 and 50 years younger. Interestingly, there was a dose effect here in that people that received just a version of the task that involved the driving and not the perceptual discrimination, they did have some improvement, but then and then the people that didn't have any intervention followed the same trajectory of cognitive decline. There were a lot of other features of this study, which is why it probably passed muster to get published in Nature. There were brain-related changes in the group that received the intervention. They were also sort of dose-related with the two types of the prototype. those brain changes measured through EEG, which was specifically related to midline frontal theta power, which is a marker of ADHD. Those were correlated with the performance in the task. We also saw transfer of benefit in that tasks, in addition to just attention, but also working memory, were improved in the group that got the multitasking version of this prototype. And then finally, the results persisted. So at 1 month here is when they stopped the intervention, but then 6 months later, with no intervening treatment, the group that got the multitasking was still performing significantly better than the other two groups. So this early phase research then led that was what started the company, and they formed this. This was when we got involved, and the company came to us and said, we want to do a proof of concept study. We'd like to see in a clinical population. We think that even though we tested this in older adults, we think that ADHD is a good indication given what we've seen in the EEG findings. And can we do a small scale proof of concept study to see if this might have some promise? So we conducted this study along with one other site in the U.S. Where we brought in kids. This was an open label trial. We brought in kids between the ages of 8 and 12 who had either verified ADHD and who weren't also taking medicine. And we also, for this particular study, we wanted to look at a group of neurotypical children. We brought them in, we did our sort of traditional clinical trial assessments of ADHD, and then gave them the treatment for 30 days, 5 days a week, for 28 days actually. And the intervention was about 20 to 25 minutes per day. And then at the end, what we wanted to look at specifically was performance on a computer-based measure of attention called the TOVA. The reason for selecting that outcome versus a more traditional outcome like symptoms is that this treatment is sort of thought to be more specific to attentional functioning rather than the broad range of ADHD symptoms. So these are the results. I'm showing you the results from the ADHD group. The neurotypicals actually showed very little change in their TOVA scores, but what you can see is for the total group of ADHD participants, there was a significant improvement from pre to post on their attention performance index on the TOVA, and this effect was even stronger for a subset of kids whose attentional performance at baseline was even worse, and that represented about half of the sample. And a third of these kids actually moved into the range on the TOVA, which is also an FDA cleared device for aiding in the diagnosis of ADHD by assessing attention. We saw those kids move into a range that's considered neurotypical. So this was very safe. We had no adverse events reported. There was good compliance with the treatment. And from a user experience perspective, the majority of parents reported that they felt that that it was a worthwhile or very, very worthwhile exercise. So this led the company then to say, we really think we have something here. It is important for us, this being Achille, to differentiate what we have versus other products in that crowded marketplace. And what we want to do is we want to actually go down a pathway to get regulatory clearance for this device, such that it would actually need to be prescribed, and the FDA would be able to say, yes, we've cleared this. And this was a business decision for the company, for them to say, we think this is going to differentiate us from these other products. So this is where we also helped out. We designed this pivotal registration study. We coordinated this study through the Duke Clinical Research Institute, where I spend some of my time as a faculty member. And this was the study that was ultimately published back earlier this year. And I will spend the rest of the time before we have debate to walk through this trial. So this was a multi-center randomized controlled trial. There were 20 sites distributed across the United States. The design was very similar to the proof of concept, with the exception that we had a control condition. In that control condition, kids were randomized to get either the active treatment or the control condition. The control condition was a word game where kids saw a matrix of letters and had to spell as many words as they could out of that matrix. And the company had actually done some preliminary work that we helped them with to ask parents, what do you think there would be a benefit if your child played this words game? And this is related to a very important feature of it in the same between the two treatments. And in fact, in the work that was done prior, there was an equal amount of expectation of benefit for both the active and the control condition. Could say a lot more about that, but in the interest of time, I'll move on. But suffice it to say that the control condition, we felt was adequate to control for bias about whether or not they were getting, whether parents or the patients were getting the active versus the control. This was 8 to 12-year-old kids, similar treatment regimen. We did allow kids at screening, if they were treated, to come in, provided that they washed out, so that during the active treatment, these were kids that were not concurrently receiving any other therapies for ADHD. And our primary outcome was the TOVA, just like it was in the proof of concept. So this is the disposition over here on the right, our consort diagram. We assessed a lot of kids. I left out an important detail. We included, as part of our eligibility, we wanted kids that had that demonstrated attentional deficit on the TOVA. So we set a threshold on the TOVA that kids had to be below in order to come into the trial. That is in part the reason why we had a large number of kids that were assessed that didn't get randomized, is because they might have had ADHD, but their attentional performance on the TOVA was actually higher than what our criterion was. But we ended up with nearly 350 kids randomized across the two treatment conditions. Across treatment, the compliance was quite good. This is just a list of how we defined our different analysis populations. I will skip over that for now. The demographics and sort of baseline characteristics of the sample were comparable across groups, so the randomization worked. And this is the safety outcomes. We had 11 treatment-related AEs with the active treatment. There were no serious adverse events. I want to highlight this because in a traditional pharmacological trial, you typically have adverse events occurring in 60 to 70% of the participants. Here we had a total number of just 11. So this highlights I think one of the advantages of digital therapeutics in general is that they're very, very safe. Interestingly, the most common AE that we saw was frustration. The kids they got frustrated when it got harder. So this is our primary outcome. This is performance on the TOVA. Improvement is showing, an increase here. This was statistically significant. We also, when we looked post hoc at the within group change, we saw statistical significance for change. Here we saw absolutely no placebo effect. So there was no change in the TOVA for the kids that were assigned to the control condition, to the words. These are our secondary outcomes, and we had a range of them. Many of them were more traditional ADHD symptom rating scales. This is the inattentive subscale, the proportion of kids that showed more than a 30% improvement, parent-reported attention, child-reported attention. We measured the impairment rating scale, which is an ADHD-specific measure of day-to-day functioning. And as you can see, although all of these didn't achieve statistical significance, there was definitely a sort of a shift as you see if the middle of these bars on this plot are beyond the dotted line, it favors treatment. So there was a clear trend towards favoring treatment here. So this study, as well as another one that we've just wrapped up and submitted for publication that looked at kids who were also taking medicine, as well as a longer duration of treatment, results were very, very similar. Those study results were the basis for the company to submit this to the FDA for clearance. which it just achieved as of June of this year, so a couple of months ago. And this was a big deal. This was a big, it made a lot of headlines. This was actually a press release that was issued by the Food and Drug Administration. So they themselves felt like this was a kind of a landmark decision that they had made. The company, and this is a little screenshot of the piece that was on Good Morning America, which is a very popular news program here in the United States. But not all of the press was positive. In fact, there was a somewhat controversial piece in the Washington Post, which is one of our leading newspapers, saying with experts in the field claiming that this was a marketing ploy. Personally, and all my biases admitted, I think that the reporting in this particular story was interesting because I don't think that the experts that they elicited input from had a full appreciation for the rigor of the science that went into the application to the FDA. So in terms of conclusions and next steps, I mean, this, as you've already heard from the other presenters, digital medicine for ADHD and for mental health is really in its infancy. And the opportunities, some of the things that were presented with the EMA study are just amazing, with voice analysis and passive monitoring of things. We really are at the beginning of a revolution. One of the things that I feel extremely strongly about is as we transition these digital tools to actual treatments, it is critically important that we develop a strong evidence base. I was really interested to see the upcoming study, Luis, that you have for the Focus app, and sort of looking at how it's going to affect adherence, because that clinical evidence is what we need to increase consumer confidence, to increase provider confidence that we have tools that work and that are different from from things that somebody might develop in their basement and put on the App Store. So I think with that I will stop. Thank you very much for allowing me to present the results from the study, and look forward to the debate.
Thank you very much, Dr. Collins. Wonderful presentation. In fact, before getting back to Dr. Rode, I would like to ask you all of you about what is the real incidence of ADHD, and are there different levels of the disease, different stages of the disease, so we can have a better idea of the incidence and prevalence of this disease, since it could be diagnosed both in children and adults. What is the incidence? What is the importance of this disease nowadays?
Do you want to address it, Scott?
Well, I can. Although I will be citing the work that you and Guillermo have done on worldwide prevalence. So, in general, the prevalence rates across the world are somewhere between 5 and 8%. They drop off a little bit as you move into adulthood. But one of the things that I always highlight that I think is critically important, so that by itself is a high prevalence. 1 in 20 kids, very conservatively, is going to be affected by this, and maybe 1 in 30 or 1 in 40 adults. But if you look at some of the negative outcomes associated with ADHD, like driving accidents, risk for substance use, suicidal behavior, these things relate not just to clinical diagnosis, but to the prevalence of symptoms in the population. So even if you're not at threshold for meeting a clinical diagnosis, if you have a few extra symptoms compared to average, you are at high risk for all sorts of negative outcomes. So the development of interventions that can address this spectrum of problems, I think, is really important.
Just adding one comment is that one important issue is in terms of subtyping the disorder. You asked about stages. We are trying, because ADHD is a syndromatic disorder, so we have a huge heterogeneity in the phenotype. One important thing that I think that Scott tackled was the fact that, for instance, in their randomized clinical trial, they selected children with ADHD and also with a clear neuropsychological impairment measured by the TOVA assessment. So I think that it's important to try to understand, and I think that the field is moving a lot in the way of understanding this heterogeneity and trying to decrease the heterogeneity to better conceptualize what are the trajectories associated more impairment. I want to make a question to you while we are waiting for more questions, Scott. Why do you decide to use, it's not very clear to me, the decision of using the TOVA as the primary outcome, because this is a major issue. We did a study using the CS8 with the guys from Yale protocol, and we decided to use the parent rating as the majority of other studies as a primary outcome measure. Why your group decided to use a neuropsychological measure and not a phenotypic measure?
Yeah, so that's a really good question, and one of the more this was actually even a point of discussion with the FDA as they were evaluating, because traditionally it's a parent or clinician reported symptom rating scale that's used as the primary outcome. The reason that we chose the TOVA was because this treatment was really designed and thought to be not necessarily a treatment for the hyperactive and the impulsive symptoms of ADHD. And in fact, the FDA, the indication for use is very specific, and it is for the treatment of inattention. And so I think this is both a scientific decision on our part, but also the company's decision to say, you know, we want to keep this very focused on what we think the treatment is addressing, and not try to cover other things that it's not addressing.
When we talk about video games, generally one thing that is already recognized about video games intervention is the increase of resilience. Since you are doing some intervention over behavior modulation, what is the basis for, what's the rationale behind the use of this video intervention over the mental health?
So if I'm understanding the question, is, you know, why are you asking why we wanted to study this as an individual treatment without other treatments?
Is this based on a behavior intervention and behavior modulation?
Got it. Yeah. No. So there's actually there are other apps for other types of mental health problems, like addiction or sleep or mood disorders, that take traditional cognitive behavioral therapy treatment and put them in an app. This treatment that I described is different. And in fact, again, in our discussions with the FDA, as we worked with the company, we had to distinguish why this video game was not the same as behavioral therapy. It's doing something different. It's doing something that's fundamentally different. If you think back to the EEG findings of the original study, that's what this treatment is doing, as opposed to specifically focusing on, you know, changing cognitions and behaviors and things like that.
We have, Scott, here one question from the audience. It's from a professor from Federal University of São Paulo that is attending our Grand Round, Pedro Pan. He's asking about the devices. Why do you think that non-pharmacological treatment interventions do not need to follow the same route or the same pipeline for approval of as the medicines? Why do you think that they have a different track?
Hello?
Hello. Can you get it?
I'm sorry, Luis.
I will repeat the question. This is a question from Professor Pedro Pan from the Federal University of São Paulo. He's asking, why do you think that there is a different track for digital intervention or non-pharmacological intervention for mental health in FDA, different from the track of medication?
That's a very good question. And so with the FDA, digital interventions are being regulated through the same broad group that regulates devices. I will say, having worked with this now for several years with this sponsor as well as other sponsors, the FDA, even though I think they've made great progress, they are still trying to figure out how to regulate these digital devices. Sentiment at the FDA that we want to promote innovation and we want to promote safe products, but then at the level of the actual review, what my experience is, the reviewers are still treating these like they are drugs. So the way that they think about and evaluate safety and efficacy. So I think that to specifically answer the question, I mean, I think they're on different tracks because they are very different overall in terms of how you think about safety and efficacy. But I think we've still got room to grow with the FDA and other. I mean, I think there's other variability in other regulatory bodies across Europe and Asia. I don't know as much in the Southern Hemisphere about sort of where the regulatory agencies stand. But it's a really good question that I think we are all working together on.
It's 12 o'clock. We have lots of questions, but let me ask you the last one. This is from one people also from the community. They are asking, how about the construction of the ecosystem that allowed the construction and development of the solution? Who was involved in the process?
Yeah, so this was when this company formed around the core prototype that was developed at UCSF. They brought in app developers, video game designers, as well as other IT specialists to really build and they've built a very robust ecosystem to be able to have this product out in the hands of what will eventually be many probably thousands, if not more, kids, bringing in the data to servers internal to the company. They're having to work on a new system for actually writing the prescription, because it's going to be a different path to actually getting the device and filling a prescription. It's not the same as going to the pharmacy. So all of that was developed within the company themselves.
Thank you very much, Scott. It's 12 o'clock. We have the tradition of having the meeting, if I'm not wrong, Professor Fleck, but it's a 1-hour meeting, and it's time to finish. I would like to thank you, Giovanni, for the very nice work that Rian Pedupan is developing with our high-risk cohort. And thank you, Scott, so much for being on board and joining us in this presentation. Was very nice. You brought a lot of new things for us to think about. Thank you very much, Scott. And I will turn to Professor Fleck to say the last words.
It was a wonderful meeting. I think I learned a lot, and I think everybody have a good time participating on this meeting. I would like to thank you, Dr. Luis Augusto Rodi and Dr. Giovanni Salum, both professor of psychiatry at the Federal University of Rio Grande do Sul. And I would like to especially thank Dr. Scott Collins, professor of the Department of Psychiatry and Biological and Behavioral Science at Duke University School of Medicine. It was a wonderful meeting. Thank you very much for attending this meeting. And I hope to see you soon. Thank you. Bye-bye.
Bye-bye. Bye. Thank you, Scott.